Shall I start, ma'am?
Okay, Ashmita.
No, ma'am. Just it takes only 1 few.
Vijay has joined. Ashmita. We can start.
Yes, ma'am.
Yeah.
Good evening, one and all. We welcome you to another episode of the Wednesday Special Thyroid Clinics organized by the Indian Thyroid Society. So before we start off, let us traverse through the journey of ITS. It was established and registered in 2003. It's a national body of healthcare professionals with special interest in thyroid disorders. So it includes endocrinologists, endocrine surgeons, nuclear medicine physicians, general surgeons, and ENT surgeons. ITS is a member of the Asia-Oceania Thyroid Association, that is the IOTA. It has currently nearly 2,000 members. So the executive committee members include the founder president, Professor R.V. Jaikumar sir, and the present president, Professor Sarita Bajaj madam. Also included in the executive committee is Professor Rajesh Udpu sir, who is the past president, Dr. Arun Menon sir, who is presently the secretary, and Dr. Mini G. Pillai ma'am, who is the treasurer. So also Dr. Himagirish K. Rao sir, who is the vice president, the scientific committee coordinator, Dr. Pramila Kalra ma'am, and the joint secretary, Dr. Sujoy Ghosh sir, are members of the executive committee. Dr. Shashank Joshi sir, Dr. P.K. Jabbar, and Dr. Krishna Sheshadri are also members of the executive committee. Dr. Mohammad Riaz, Dr. Sushil Gupta, and Dr. Ashraf Jani are also members of the executive committee of the ITS. So the aims of the ITS is to organize academic activities for healthcare professionals, to promote public education and awareness about thyroid disorders, to encourage research in thyroidology, and to encourage publication in the flagship journal, that is Thyroid Research in Practice. It is also to have the state-of-the-art publications and to award fellowship of the society and to encourage membership of the society. So the ongoing activities of the Indian Thyroid Societies are, it is to organize the CMEs, updates, symposia, and conferences. Also, thyroid clinics are were being held weekly, but now presently fortnightly. They mainly include journal club, the case conversations, the monologue, the dialogue, the panel discussion, meet the professor session, the quiz, workshop, and the CTCs. The programs organized by the Indian Thyroid Society are the Thyroid Awareness Week, which is celebrated on May 22nd, from May 22nd to May 28th, the World Thyroid Day, which is celebrated on May 25th, and the Thyroid Awareness Month, which is celebrated annually in the month of January. The Indian Thyroid Society has multiple research activities as well. It is to provide annual grants for original research studies focused on thyroid and related disorders, preferably in the Indian context. Research grants are available, and to apply for these grants, details can be accessed in the website, that is the www.indianthyroidsociety.in. So coming to the journal of the ITS, that is the Thyroid Research in Practice, it is basically published twice a year in print and online. It has a quick turnaround time. Electronic copies are available ahead of print. Fellowship is also awarded by the Indian Thyroid Society. It is basically awarded to the ITS members who have expertise and experience in the field of thyroidology. It will be selected by an expert panel. The eligible members will be conferred the Fellow of the Indian Thyroid Society, that is the FITS. So there are numerous publications also by the Indian Thyroid Society. That is the Clinical Manual of Thyroid Disorders, first edition, edited by Professor R.V. Jaikumar sir. Also, numerous guidelines have been published by the Indian Thyroid Society. The thyroid dysfunction in pregnancy, guidelines for the management of thyroid dysfunction during pregnancy, hypothyroidism, and diabetes. Also, other guidelines like the consensus on the management of subclinical hypothyroidism, guidelines for the management of dyslipidemia and thyroid dysfunction, and guidelines for the management of depression and thyroid dysfunction. The upcoming publications by the Indian Thyroid Society include the ITS Clinical Manual of Thyroid Disorders, that is the second edition, the chief editors of which are Dr. Sarita Bajaj Madam and Dr. Rajesh Rajput sir. There are upcoming guidelines are also going to be published in the year 2022 and 23, which include the management of subclinical hypothyroidism, management of thyroid disorders in pregnancy, and management of thyroid carcinoma. Can we go to the next slide, Asmita? The website of the Indian Thyroid Society is the Indian Thyroid Society, www.indianthyroidsociety.in. It has numerous contents, that is, it has link to the guidelines, access to the ITS journals, and records of all the academic activities. And also it has an online membership portal. The next slide, Hasmita. Yeah. So the membership of the Indian Thyroid Society can be awarded to all the previous slide, please. Can be awarded to all the modern medical practitioners in India. There are two types of life membership which are awarded. The full-time life membership, which is basically awarded to the specialists in the field of endocrinology, endocrine surgery, and nuclear medicine. The second type of life membership includes the associate life membership, where all the other registered medical practitioners can avail it. Next slide, please. So the applications for the membership are invited online, that is on the ITS website, which can be accessed on the following link, that is the indianthyroidsociety.in. So before we start off, can we have the quiz participation rules slide as well, Asmita? So the quiz will be held today between 8:40 to 8:50 p.m. So here are the quiz participation rules. That is, to participate in a quiz, having the Zoom app on your mobile device or laptop is required. You are requested to use a laptop for the ease of experience. The quiz will run for about 10 minutes. There will be first 2 dummy questions followed by the actual quiz. The quiz master will display the case or the description of the question by screen sharing a PowerPoint file. The participants should use the polls option to participate in the quiz. All 10 questions will be available when the poll is launched, and answer for all the questions will be submitted at the end of 10 minutes. To read the case or description, you can choose the polls using the X button and again use the polls option to answer the respective question. So can we have 2 dummy questions, Asmita?
Ganvi, I think we'll do that during the quiz.
Okay, ma'am.
Let's move on, please.
Yes. So the Thyroid Clinics webinar is being conducted under the leadership of the 4 conveners, that is the distinguished president of the Indian Thyroid Society, Professor Sarita Bajaj Madam, the scientific chair of the Indian Thyroid Society, Dr. Pramila Kalra, treasurer of Indian Thyroid Society, Dr. Mini G. Pillai Ma'am, and secretary of the Indian Thyroid Society, Dr. Arun Menon sir. So today's program, basically we are having 2 case discussions moderated by Dr. Maithili ma'am and Dr. Anurag sir, and we have the chairperson for today's session, Dr. Vijay Sathi sir. Also the quiz will be conducted by Dr. Lakshmi Nalini Koppale ma'am. So before we start off, so we will start off with the first session with the introduction of our esteemed chairperson, Dr. Vijay Sathi sir. So, Asmita, can we have sir's CV, please? Sir, Dr. Vijay Sathi, sir, is the professor and head of the Department of Endocrinology, Vaidehi Institute of Medical Sciences and Research Center, Bengaluru. Sir is the editor of Cape News. He was the editor of Cape News between 2014 and 2018. Sir has more than 100 publications in national and international journals to his credit. Sir has been awarded the Best Resident Doctor at KEM Hospital, Mumbai in the year 2012. Sir has also been awarded the Young Investigator Award in Vellore in 2013. Sir has been also awarded the A.V. Gandhi Award for the Best Research Methodology in 2012. So it gives me extreme pleasure to invite our distinguished chairperson, Dr. Vijay Sathi, sir. Sir, I now request you to say a few words and to introduce Dr. Maithili ma'am. Over to you, sir.
Good evening, everyone. Thank you so much, Dr. Ganavi, for the kind introduction. And I would also like to thank Sarita ma'am and Pramila madam for making us part of this great event, which is going so well every alternate week, giving so much of knowledge on thyroid for the, like all endocrinologists as well as the medicine colleagues. So it's a great pleasure to be part of this today. And without spending much time on this, I would like to introduce Maithili ma'am. Can I get the slides on to introduce madam? Anyhow, I know very well about madam. Without the slide, I can introduce her. Madam is a former professor at Andhra Medical College at Visakhapatnam. She is currently working as a consultant endocrinologist at Visakhapatnam. And she's also a visiting faculty at GEMS, Srikakulam. And she helps a lot of diabetic children, especially from the low socioeconomic status, by providing both financial as well as social and moral support. She's a founder secretary of Diabetic Child Society at Visakhapatnam. And she's also currently the president-elect of Andhra Pradesh RSSDI. More than anything else, she's a very good human being. You reach her for any help, she's always there to support us. So very warm welcome, ma'am, for the session. I would like to take over the session and moderate the first case.
Thank you, Vijay. Thank you.
Thank you, ma'am.
So thanks for all the kind words you spoke about me. And first of all, I thank Dr. Sarita Bajaj for her kind invitation asking me to moderate today's session. And today we have a very interesting case presentation by, we will, can I have the speaker's CV? So the first case presentation is with regards to hypothyroidism management and headache. So this case will be presented by Dr. Nitin, who is a senior resident. Of course, I think under the guidance of Dr. Vijay, I think that is his plus point. And he is presently working at Vaidehi Institute of Medical Sciences and Research Center, Bangalore, India. So Nitin will do three things. One is I will interrupt you at the end of history. Then the second interruption is after examination. And finally, closing comments at the end. So this is how we will proceed. So over to Dr. Nitin for his presentation.
Yes. Can you see my slides, ma'am?
Yeah.
Yes.
I think you can do the slideshow.
Yeah, slideshow.
Good evening, respected professors and everyone. Today I'm going to present an interesting case of a 46-year-old woman hailing from West Bengal who presented to a local physician on 26th of November 2021 with initial complaints of dryness of the skin since 2 years, constipation since 2 years, lethargy since 1 year. Coming to history of presenting illness, she was apparently all right 2 years ago when she noticed dryness of the skin over her forearm and face, history of constipation since 2 years, one bowel movement for 3 to 4 days with history of straining and passing hard stools without any blood in the stools. There was also a history of lethargy with excessive sleepiness and forgetfulness since 1 year. There was also a history of weight gain of around 8 kgs in the last 1 year history of reduced appetite and cold intolerance since 1 year, history of swelling of the lower limbs since 1 year associated with periorbital puffiness, no diurnal variation seen. There was no history of breathlessness, chest pain, palpitations, syncope, distension of abdomen, jaundice, decreased frequency of urination. There was a history of muscle pains, diffuse, more in the muscles of the arms and thighs. There was no history suggestive of proximal muscle weakness. There was no history of swelling in the neck, difficulty in swallowing, no history of change in the voice, no history of paresthesia, paleness, no history of headache, vomiting, blurring of vision, no history of any neck surgeries, radiation, no history of nausea, hypopigmentation, white patches on the body, polyuria, polydipsia. For the above complaints, she was diagnosed to have hypothyroidism and was started on levothyroxine 100 mcg per day at an outside clinic. She presented to our OPD 1 month after starting levothyroxine replacement on December 29, 2021 with complaints of continuous holocranial headache since 15 days. Headache was gradually increased in intensity and was more in supine position and after waking up from the sleep. Since past 10 days, headache was also associated with photopsia, nausea, and occasional vomiting. She also noticed blurring of vision while looking straight since the last 15 days, associated with double vision in both eyes on looking sideways. There was no pain in the eyes in the neutral position or while looking sideways, redness of the eyes, or watering of the eyes. And no history suggestive of other cranial nerve involvement was present. And there was no history suggestive of postural giddiness, hypoglycemia, polyuria, polydipsia. Patient also reported improvement in muscle pains, periorbital puffiness, and lower limb swelling, along with 4 to 5 kgs of weight loss over this 1 month. Coming to past history, it is nothing significant. Family history, no history of similar complaints, neurological illnesses in the family. Personal history, she takes iodized salt. She does not belong to iodine deficient region. Appetite was normal, sleep was normal, bowel and bladder were regular. She's married since 25 years, completed her family, has 2 children, attained menopause 5 years ago.
Yeah, thank you, Nitin. I think this is a very meticulous history taking. So as described by you, this is a very obvious, very typical presentation of primary hypothyroidism, overt, and the problem is headache. So what are all the possibilities at the end of history for headache and hypothyroidism in this case?
First possibility can be she can have raised intracranial pressure symptoms. One of the symptoms is headache.
Good.
And she can have any cellular mass causing secondary hypothyroidism with headache. And third one, very rare, was like hypothyroidism with pituitary apoplexy can also be a possibility.
So if you look at this patient's headache, it is, as you described, it is very continuous headache.
Yes.
It is, you said it is early morning, associated with nausea. There are some visual deficits which you have mentioned.
Yes,
and then the headache is also increasing in intensity, right? So
yes,
I think these are the pointers to say that this is probably a raised intracranial tension.
yes.
That is number one. You have any other causes of headache in hypothyroidism? What else I would like to mention is always think of a sleep apnea. So sleep apnea can occur in hypothyroidism, and sleep apnea is one of the causes of early morning headache in hypothyroidism.
Okay.
Then the other thing is, can untreated hypothyroidism present with raised intracranial tension? You were also mentioning about the pituitary part. So if somebody has untreated hypothyroidism, can they come with severe headache? That also is possible, right? Because
yes,
the pituitary hyperplasia, which occurs,
yes, ma'am.
that can produce a severe headache. And often we see, untreated hypothyroidism patients, they complain of headache.
Yes,
so headache and hypothyroidism, I think number one is, as you said, think of a raised ICT. If you want to combine both primary hypothyroidism and headache, so the possibility is number one, raised ICT. And the second possibility which we need to keep in mind is a sleep apnea, a central sleep apnea or even an obstructive sleep apnea. So that can also produce early morning headache.
Okay.
And then, of course, if you are thinking of a central cause of SLR mass, definitely a combination of severe headache, increasing in intensity associated with visual blurring, and that also fits into a SLR mass with raised ICT. That is the second possibility. Now, there is another thing you mentioned about the blurring of vision in primary gaze and double vision sideways. So how can you explain this?
Patient had double vision due to lateral rectus palsy, ma'am. And blurring of vision due to papilledema, they can have the blurring of vision, ma'am.
So papilledema by itself doesn't produce visual deficit, doesn't produce a visual blurring, but transient, we call them transient visual obscurations are described in papilledema. That is probably one way to say that blurring is there. Yes. And then the typical description of double vision, patient looks to right or left, probably points out towards a horizontal palsy. You also asked for a history of oral contraceptive pills, a history of OC pill usage in the past, a history of COVID-19 infection. How is it relevant? You want to link both headache, OC pill, COVID-19. Again, these are all the other causes of IIH, idiopathic intracranial hypertension or pseudotumor cerebri. These are the other causes. Obviously, we know the diagnosis, right? So these COVID-19 infection has been associated with pseudotumor cerebri. And then, of course, OC pills have been presently, not in the past. Vijay, you want to add something?
Absolutely fine, ma'am. I think the discussion points, what you took were very relevant and they're going ahead. Probably that the sleep apnea part and the other causes of headache were actually a little lower on the card because of differential diagnosis, because the temporal relation of the onset of headache to the treatment actually.
Absolutely.
So that was something which was taking intracranial hypertension as on the top row.
Yeah.
But of course, I would absolutely agree with you. These are all the very well known causes of headache in primary hypothyroidism. And we should entertain all these things.
But this is only for the learning part that we should think of sleep apnea. So sleep apnea, usually headache resolves with starting levothyroxine. Unlike this case where starting levothyroxine exacerbated the headache. In fact, headache was after levothyroxine treatment. That is again sleep apnea. Right. So you want to relate this patient, you said put on weight. You want to combine weight and headache also, Nitin?
Yes, ma'am. Obesity.
Yeah.
Obesity is one of the risk factors for raised ICT also.
Yeah. That is also another reason.
Yes. Sorry, ma'am. Actually, I had a power breakdown. Actually.
So we'll proceed further examination.
Yes. On examination, her pulse rate was 70 beats per minute, regular, normal in volume and character. BP was 128 by 90 mmHg, right arm supine posture, no postural drop seen. Respiratory rate was 14 cycles per minute, temperature febrile. Her weight was 78 kgs, height was 166 centimeters, BMI was 28.3. Local examination, she has dry skin, grade 1 goiter. Her hair and nails were normal, no pedal edema was seen. Coming to CNS examination, higher mental functions was normal. Visual acuity was 6 by 24 in the right eye and 6 by 36 in the left eye. Color vision was normal. Fundus is showing both eyes papilloedema, established papilloedema grading, and according to modified Friesen score, it is grade 5. Cranial nerve examination, bilateral LR palsy was present, no ptosis, pupils were normal. Rest of the cranial nerve examination was normal. Examination of the motor system and sensory system, cerebellar system, meningeal system was normal. Rest of the systemic examination was normal. Provisional diagnosis, A 46-year-old postmenopausal woman having grade 1 goiter came with signs of raised intracranial pressure following initiation of levothyroxine replacement. So my first DD would be idiopathic intracranial hypertension. Second DD would be cellular supracellular mass with secondary hypothyroidism. Third DD would be primary hypothyroidism with pituitary apoplexy, which is very rare.
Why did you put this order? First, you said first one is primary hypothyroidism plus IAH, isn't it? That is first. So the second one is a cellular supracellular mass with secondary hypothyroidism. And third, if you look at, these three, which is common within, you think, isn't it? So,
yes.
So you think it can be, we still don't know the investigations part. So
yes,
the typical headache increasing in intensity associated with progressive diminish of vision, I think you should also suspect an expanding supracellular mass with secondary hypothyroidism. That is also equally common. But the point against secondary hypothyroidism in this case, I would say, is the presence of a goiter, I think you mentioned.
Yes, ma'am. Goiter was.
What we can say is the presence of a goiter usually favors a primary hypothyroidism, usually. But then, so that is the point against. And I think the typical overt presentation, that is also against secondary hypothyroidism. So as you said, the symptoms are severe, which points towards a primary hypothyroidism. But primary hypothyroidism with IAH is relatively rare when compared to a cellular mass with this picture. And finally, apoplexy is usually, it is like a bolt from the apoplexy doesn't stay for so many days. It is usually a very severe, sudden onset of severe headache, and then there is a visual loss. So apoplexy, I think I wouldn't consider, but both these primary hypothyroidism with idiopathic intracranial hypertension, which is rare. And secondly, a cellular mass is also, I think we need to keep in mind. Right.
Okay.
Anybody else would like to give any comments? Okay. Okay, proceed. Vijay, you want to add something?
Yeah, one small point I just wanted to add. I absolutely agree with you that like hypopituitarism, typically when they have a concomitant cortisol deficiency, they don't commit a florid hypothyroid manifestations. But we do have some maybe 2 to 3 cases of isolated TSS deficiency in a patient with pituitary adenoma, in fact, who had a florid hypothyroid manifestations. So though these florid manifestations of hypothyroidism makes primary hypothyroidism much more likely, but may not rule out secondary hypothyroidism. So though rarely secondary hypothyroidism, especially with isolated TSS deficiency with a normal cortisol, can present like that.
Please proceed.
Okay. So these are the investigations in November 2021, pre-levothyroxine treatment. Her TSH value was grossly elevated with the value of 319 and free T4 was almost undetectable with 0.04 nanogram per deciliter. Hemoglobin was 10.4 gram per deciliter. Fasting plasma glucose was 86. Creatinine was 1.17 mg per deciliter with eGFR of 58 ml per minute. Her total cholesterol was 253 mg per deciliter. LDL was 180 mg per deciliter. Her HDL and triglycerides were normal. These are the investigations when she presented to our OPD in December. And her TSH was reduced to 21.5. T4 was 12.35. T3 was 0.85 nanogram per deciliter. 8 AM cortisol was 17.1 microgram per deciliter. Creatinine was 1.06 mg per deciliter with eGFR of 66 ml per minute. Her electrolytes were normal. Fasting plasma glucose and HbA1c were normal. Hemoglobin was 10.6 gram per deciliter. An MRI brain was ordered, and this MRI brain is showing, this is a T1 weighted coronal section, and it is showing partial empty cella with a pituitary height of around 3.6 mm. And coming to MRI brain with contrast, there is an uniform enhancement with partial empty cella. So levothyroxine replacement was stopped. After taking neurologist opinion, we have done guarded LP, which revealed an opening pressure of 32 centimeters of water. 30 ml of CSF fluid was drained and CSF analysis was normal. Patient reported immediate improvement in headache after LP, and by 24 hours, there was significant resolution of headache and diplopia, along with improvement in lateral rectus palsy. Over the next 2 days, patient also noticed improvement in her vision. This is the modified Dandy criteria used for IIH. It includes signs and symptoms of raised intracranial pressure, no localizing signs in neurological examination except abducens nerve palsy, normal neuroimaging except empty cella, opening pressure of LP greater than 25 centimeters of water with normal CSF, alert and awake patient. No other cause of raised ICT should be there. Final diagnosis was primary hypothyroidism with idiopathic intracranial hypertension, secondary to rapid levothyroxine replacement. Coming to advice, we have started her on low doses of thyroxine and gradually increased to 100 mcg over 6 weeks. And she was also advised to take acetazolamide 250 mg TID for 3 months according to neurologist. And she was advised to review after 6 weeks for fundus examination and visual acuity. On follow-up, she came for review 3 months later, wherein there was no headache, nausea, vomiting, and visual symptoms. Her extraocular movements were normal in all directions, and fundus revealed resolved papilloedema with normal optic disc and spontaneous venous pulsations. Her TSH was 5.5 and T4 was 10.85 microgram per deciliter, T3 0.75 nanogram per ml, and she was continued on 100 mics of levothyroxine, and she is due for follow-up. So this case made us keen regarding IIH following initiation of levothyroxine therapy, for which we did a systematic review. So we identified total 44 records, out of which 21 records were included following screening. Coming to results and discussion, out of 21 patients, majority of the patients were children and only 6 patients were adults. 7 are males and females of 14 in number. And the duration of hypothyroid symptoms at the diagnosis of hypothyroidism was 4 years, and duration to onset of IIH symptoms was 1.5 months, and duration to diagnose IIH after initiation of LT4 replacement was 2 months. So there was an average delay of 2 weeks before identifying the cause of raised intracranial hypertension. So these are all the cases included. This shows out of 19 patients, papilloedema was seen in 18 patients, absent spontaneous venous pulsations in 4 patients, retinal hemorrhages in 2 patients, lateral rectus palsy in 6 patients. Coming to MRI findings and CSF opening pressure, median CSF opening pressure was 35 centimeters of water, and 10 patients had MRI features of raised ICT, while the other patients were diagnosed based on the papilloedema or elevated CSF opening pressures. Biochemical parameters and IIH. At the diagnosis of hypothyroidism, majority had severe hypothyroidism with a median TSH of 100 milliunits per liter and very low T4 of 1.13 microgram per deciliter. And at the time of diagnosis of IIH, most patients had almost normalization of TSH and T4 with values of 2.2 and 8.90. And median starting LT4 dose, majority of the patients were started at higher doses, that is 87% of the maximum recommended LT4 dose. And similarly, majority of the patients were taking higher average LT4 doses, that is 89% of the maximum recommended dose. Coming to correlation of CSF opening pressure, females have higher opening pressure than males, but it is not statistically significant. And there was no correlation of CSF opening pressure with any of the hypothyroid associated parameters at the time of diagnosis of hypothyroidism or IIH or any other therapy related parameters. And there was also no correlation between thyroid profile at the time of diagnosis of IIH and duration of IIH symptoms. And these are the mechanisms. Actually, exact mechanism is not known. These are the proposed mechanisms for IIH in hypothyroidism. Severe hypothyroidism leads to impaired excretion of water and tendency towards hyponatremia. So rapid correction of hypothyroidism may lead to altered CSF dynamics leading to IIH. And in lower animals like frogs and snails, TRH was shown to have osmoregulatory function, and it has also effect on vasopressin secretion in humans. And one more mechanism was in hypothyroidism, cortisol production is diminished. So rapid correction with thyroxine therapy may accentuate the hypocortisolism, mimicking an acute Edisonian picture, another condition which is commonly associated with IIH. And obesity, which is often observed with IIH and occasionally with hypothyroidism, increases the percentage of androstenedione, that is aromatized to estrone, which has been proposed to increase the CSF production. And these are the mechanism for empty cella in IIH. In long-standing primary hypothyroidism, thyroid lactotrope hyperplasia may damage the diaphragm cellae. So thyroid hormone replacement causes regression of the pituitary size. So the incompetent diaphragm allows the subarachnoid space to herniate into sella turcica, and the pituitary gland is compressed, leading to an empty cella. So the learning points are IIH is more common in younger age group, especially among the pediatric age groups, and with longer duration of hypothyroid symptoms. Hence, long-standing primary hypothyroid patients should be initiated on low-dose levothyroxine and gradually increased to required doses. And also, patients complaining of new onset headache after starting levothyroxine replacement should be evaluated for idiopathic intracranial hypertension.
Thank you. Thank you, Nitin. That's a really a wonderful case and good learning points. So we have some comments in the chat box. I think some of them we have answered. So we have some, Dr. Murthy Krishna's comment is that significant papilledema and lateral rectus palsy cannot be attributed to idiopathic ICH as the first possibility. So, but by and large, in the absence of any, with a normal neuroimaging, I think a final diagnosis would be an idiopathic ICH. And there's another question or comment from Daya Kishore. Migraine precipitation after thyroxine therapy is well known. Response to beta blockers and cyproheptadine, but MRI is mandatory to exclude more severe causes of headache. Then there's another question. Can we attribute IIH to obesity? Of course, we can.
Yeah.
Right. I hope we have.
I think it's wrong sleeping postures from Dr. Surendra Gupta is asking.
Yeah, that is also used.
Yeah. And I think Dr. Muthu had asked one question, I think, which you'd already answered.
Yeah.
About sleep apnea.
The first three. There is also in the chat box.
Yes. Yeah.
Namrata is asking how to approach a patient with highly labile thyroid profile. TSH changes from hypo to hyper and vice versa within days. So actually, definitely with the changing, when we treat patients with hypothyroidism with levothyroxine, very rarely we see that some of them go into, if you are giving an optimal dose, majority of the times we optimize the dose. But there are rare situations where there is a switching of antibodies from blocking to stimulating antibodies, and these individuals can go into hyperthyroidism. So the same thing happens when hyper is treated with antithyroid drugs. There is a switching of the stimulating antibodies to the blocking antibodies, and this can occur. But of course, within days, this doesn't happen. Another question from Ashrit, 18-year-old male has total T3 122.5, free T3 3.2, total T4 6.8, free T4 1.3, TSH 8.5 with no other symptoms in the body, no weight gain, requesting the solution. So as we see here, I think the total hormones, the free hormones are all within normal range. It is the TSH which is 8.5. Well, I think this particular case, I would repeat the TSH. Then of course, if he is obese, no weight gain is there here. I think repeat TSH and then along with the antibodies, and if the TP antibodies are positive and the TSH remains persistently more than 8, then maybe we are justified in treating him with a low dose of levothyroxine.
Yeah, but the pertinent question would be as to why would a person with no symptoms, I mean, if it is absolutely normal, why did this person go in for a thyroid test in the first place? Unless it's one of, and for an 18-year-old to go in for a package or master health checkup is, I mean, you understand that could be, that is what the question that needs to be addressed here as to why would I get a checkup done in the first place?
So now everyone has a thyroid report with them.
That's what I'm saying. We are thanks to the labs.
Yeah.
We are more in business, I suppose. Yeah. So I think we have answered all the questions.
Yeah. So finally, I think, Nitin, what situations of hypothyroidism do you start levothyroxine at a low dose? Generally, isn't it? Now, generally, now we don't talk of starting with a low dose. We just start with an ideal dose, and then. But what situations? This is one situation you mentioned that severe untreated hypothyroidism for fear of IIH, for fear of its adrenal insufficiency, you start with a lower dose. Any other situation?
Any other heart patients, any coronary artery disease patients, we have to start low.
Two scenarios where you start with a low dose.
What is the age cutoff? I mean, like elderly, when we say elderly also, we'll start slow, irrespective of coronary artery disease. So what is the age cutoff? What do we, I mean, to define it as elderly, as far as treatment is concerned? I mean, below which age will you start full dose bang without, like thinking twice? Patient does not have coronary artery disease.
More than 60 years, I think so. I don't have idea about the age.
Yeah, agreed. 60, 65 even. But 60 is absolutely, you're absolutely right. Less than 60, we can start full replacement dose. Over 60, we would go cautiously. And what about, so this is an 18-year-old, reverse the age, 81-year-old. 81-year-old coming with a TSH of about 8.5.
Okay.
Everything else is
normal. TSH will be elevated in slight elevation of TSH will be there in the old people. And
so elderly above 80, even the TSH, what should be the normal TSH is not yet defined, but we would not worry about up till even 10. Definitely not. We wouldn't think about treating them. So Nitin, when you showed us the criteria for diagnosing idiopathic intracranial hypertension, which of those did your patient have amongst the criteria that you had listed?
She has raised intracranial pressure, ma'am, symptoms and signs.
Mm-hmm.
And
you can go back to that slide if you wish.
Yeah, ma'am. And she's awake, and she MRI findings were there. CSF was normal. CSF opening pressure was more than 25 centimeters. Here the pressure was 32 centimeters. And Dandy criteria was almost.
How many points did you? I mean, and
5 points were almost there, ma'am.
So how many do you need to make a diagnosis?
5.
Out of?
Actually, they didn't mention how many points, ma'am, but they gave one criteria. That's it. Like
all have to be there.
All should be there, ma'am, actually.
All have to be there.
Yes, ma'am. All have to be there.
To make a diagnosis.
Just to add up to Maithili madam's point, in fact, it's a very subtle point, but being a pediatric endocrinologist, I always take care of this. Mm-hmm. So especially the children who are coming with elevated TSH when it's more than around 50 and they're nearing their exams. So we should be a little slower because many a times these children develop attention deficits, which may badly affect the exam performance, especially they're going for 10 standard or 12 standard exams. Probably that's some particular area where we need to start slow and escalate.
Yeah. Previously, Vijay, they used to say when in children, especially if you give a full dose, there is an early closure of epiphyses. So that was another earlier.
That's even now is a concern, ma'am. In infants, and we're treating them for congenital hypothyroidism, craniosynostosis, though it's rare, but it still remains a concern, ma'am.
Yeah, but then Nitin, you also said that the thyroid hormone values don't make a difference. No? You said on one hand, you're saying chronic, long-standing hypothyroidism goes slow.
Yes, ma'am.
And then on the other hand, you also said that the T3, T4 values do not have any bearing on.
From our systematic review, we found that there was no correlation, ma'am. But
let me answer this, Nitin. Yeah. So, ma'am, actually, this is we did this analysis within a cohort of diagnosed IAH cases. Okay. Ideally, the study protocol should be we have to take all patients who present with marked elevation of TSH with overt hypothyroidism and start with a good dose of levothyroxine for all of them and see who develops BIH and who don't develop BIH, and then look at the risk factors. The major limitation of the systematic review was we did not have a control arm to look at what are the risk factors for development of IAH in a treated patient. Probably that could be the reason why we did not get any positive correlation.
Okay. Because see, some labs don't give a clear, they just say more than. So TSH more than that. So the exact, if it's more than 100, it could be anything actually.
Sure,
so I think you will have to base it on your clinical sense as to how long the patient has. And a lot of patients, even with very high TSH, they just, it's been routinely picked up.
True, ma'am.
And that is, it's very surprising.
Even in some patient who had TSH which was not more than 100, even few of those patients also developed IAH, ma'am.
So that's then it's a bit so that means how do you pinpoint a patient and say, well, this patient, children, of course, you've already clarified that they're more likely, but otherwise, how do you sort of target that this patient may get it? And then, because usually in adults, we are starting full to replacement dose according to the body weight.
Probably those who look very overtly myxedematous, probably those are the patients we need to be a little careful. Anyhow, because again, the statement is a very relative statement. Definitely, I agree with you. Those who are coming with more than 100 and with myxedematous features, probably that's something where we need to be careful, because the moment the patient has a very myxedematous features, most often there are little long-standing ones.
So I think that makes sense. Thank you. I think.
Thank you for the wonderful discussion.
Thank you so much, ma'am.
Thank you. Thanks to you. Thanks to you. That's the way case should be discussed. History, then exam, and then that is, I think, the ideal way to discuss it. Thank you. Thank you, Dr. Maithili.
Thank you.
And Vijaya and Nitin. Over to you, Gandhi.
Yes, ma'am. Thank you, Dr. Maithili ma'am and Dr. Nitin for a very enthralling discussion. Thank you, Dr. Saritha ma'am and Dr. Vijay Sathi sir for discussing the key points as well. So we shall now move on to the next session, that is the quiz. I request Dr. Vijay Sathi sir to introduce Dr. Lakshmi Nalini Koppale ma'am. So can we have the slide off, ma'am? Yeah.
So if I'm not wrong, Dr. Nalini is Maithili madam's student, right?
Yes.
Yes, that's good combo.
It's an honor to be with ma'am here today.
That's right. So Nalini is in fact like a very active member of ESI. So because she has so many things, so I don't take much time to read out this slide, but I'll give you the salient features of her. She's currently working as associate professor at Shadan Institute of Medical Sciences and also consultant endocrinologist at Fernandez and Continental Hospitals, also at Magna Clinic, Hyderabad. So in fact, she is also a sub-editor of Newsletter of Endocrine Society of India, and she recently received the President Award for services rendered to ESI. That will tell about her magnanimous services to the Endocrine Society. So with this brief introduction, I will request her to take over and continue with the quiz process.
Thank you for the kind words of introduction, Dr. Vijay Sathi. At the outset, let me thank the organizers for giving me this opportunity. Quiz is always very special because while making a quiz, it gives you an opportunity to read, learn, and study a little more. And learning is always a very good experience always. Let me share my screen.
Ma'am, can we first discuss the quiz participation rules and the dummy questions so that the participants...
Yeah, Dr. Ganavi, can you tell the rules, please?
Yes, ma'am. The IT team, can you display the quiz participation rules? Yeah, so to participate in the quiz, having a Zoom app on your mobile device or laptop is essential. You're requested to use a laptop for the ease of experience. The quiz will run for 10 minutes. There'll be first 2 dummy questions followed by the actual quiz. The quiz master will display the case or description of the quiz by screen sharing a PowerPoint file. The participants should use the polls option to participate in the quiz. All 10 questions will be available when the poll is lodged, and the answer for all the questions is to be submitted at once at the end of 10 minutes. To read the case or description, you can close the polls using the X button and again use the polls option to answer the respective question. So can we have the dummy questions?
I think after so many quizzes, we can make do with the dummy questions.
Okay.
People are now very used to taking the quiz every week.
Okay, ma'am. Yeah. Over to you.
I hope everyone is ready with the quiz. Let me just, for the quiz, let me just share my screen. So, is my screen visible?
Yes, ma'am.
Right, just a second. I'm not able to change. Right. So starting the first question. A 26-year-old man presents to his GP with a 4 centimeter mobile anterior neck mass. FNAC gives us this picture. See the slide clearly. What is the most likely diagnosis? A, thyroglossal duct cyst. B, follicular carcinoma. C, medullary carcinoma. D, papillary carcinoma. And they get 1 minute time, right?
Yes, ma'am.
Last 20 seconds. Right, 1 minute's up. So we move on to the next question. Which of the following features is not typical of Graves' disease? A, hyperplasia of the follicles. B, extensive infiltration of the mononuclear cells into the thyroid parenchyma. C, irregular shaped follicles. D, scalloping of the colloid. You have another 2 seconds left. Right. The third question. Read the question. I'm reading the question. Please pay attention. How many isotopes of radioactive iodine exist? A, 34, B, 35, C, 36, D, 37. It's a direct question. I don't think it should take a long time. So last 10 seconds. Fourth question. Probable mechanisms by which metformin reduces TSH level include all except A, changes the affinity of thyroid hormone receptor. Metformin decreases the central dopaminergic tone. C, metformin directly changes TSH regulation. D, it inhibits AMP kinase activity in hypothalamus. Read the question carefully. It is all except. Last 10 seconds. Moving to the fifth question. The usual peak incidence of thyroiditis is first and second decade, second and third decade, third and fourth decade, or fourth and fifth decade. Last 10 seconds. So that's 5 questions done, 5 questions left. So the sixth question. In 2013, Ministry of Health and Family Welfare launched child health screening and early intervention services in India. Name the scheme. It involves thyroid screening as well. So choice is, what is the first option is Rashtriya Bal Swasthya Karyakram Program, that is RBSK, or is it Rashtriya Bal Vikas Karyakram Program, RBVK, or Rashtriya Bal Swasthya Suraksha Program, RBSS, or Rashtriya Bal Swasthya or Chikitsa Program, RBSC? The time starts now. Read the names of the programs carefully. Another 10 seconds left. And the next question. During the revision surgery of thyroid gland, the risk of parathyroid injury is considered to be A, 2 times, B, 4 times, C, 10 times, D, 20 times. It's a direct question, time would be less. Ten seconds more. And the next question. What thyroid cancer has the worst prognosis? Choose the answer that shows the correct descending order. Anaplastic is greater than medullary, is greater than follicular, is greater than papillary. That is choice A. Choice B is anaplastic is greater than medullary, is greater than papillary, is greater than follicular. C. Medullary is greater than anaplastic, is greater than papillary, is greater than follicular. D. Medullary is greater than anaplastic, is greater than follicular, is greater than papillary. Read your question again. Start. So time is up. So last one question. Treatment options for methimazole-induced hepatotoxicity is A. Lithium, B. Intravascular glutathione, C. Oral zinc, D. Ethanol. So direct question time would be lesser. Last 10 seconds, please. And moving on to the last question in the quiz. An 18-year-old female presents with a painless 1 centimeter mass in the anterior neck region. A biopsy was taken. It revealed a fluid contained within a pseudostratified columnar epithelium. What is the most likely diagnosis? Branchial cyst, thyroglossal cyst, anaplastic carcinoma, or is it a dequervains? Last 10 seconds. Yes, and that concludes our quiz. The next would be answers. When would we take the answers? Ganavi, could you guide me here?
Yes, ma'am. We'll be discussing the answers at the end of the second case discussion, ma'am.
Done. So wait for the answers. The answers are right here. Hopefully you all have done your quiz well. Let me just stop sharing my screen.
Thank you, madam. So moving on to our final session is the second case discussion. Yes, sir. I request Dr. Vijay Sathi, sir, to introduce Dr. Anurag Leela, sir, who is the moderator for the second case discussion.
Yeah, so can we have a slide, please? Again, no need for slide. Is a very close friend of mine. In fact, like we worked together during our residency, even working together, at this moment also. So he is additional professor of endocrinology at St. G.S. Medical College and KM Hospital, Mumbai. He has several publications. I think it's not more than 80. In fact, they might have crossed by around 120 publications as of now. His keen areas are pituitary and adrenal disorders. His current area of work, in fact, is disorder of sex development. So, in fact, like I would like to call him as the brain of endocrinology department of KM. So, because he percolates like hypothalamus down to all the organs who are sitting and working in KM. So, with this introduction, I would like to welcome Anurag to take over and please moderate the session.
Yeah, thank you, Vijay, for the very, very kind introduction. And so we would start this session. Dr. Sidhu Nikit, he's a senior resident working with Vijay at Vedayi Hospital, would be presenting the case. Over to you, Sidhu.
Thank you, sir. Good evening to my professors, to my colleagues, and to my friends. Today, I'm going to discuss an interesting case. It's a cellular mass with a markedly elevated TSH. Is it a thyroid hyperplasia or a pituitary adenoma? 62-year-old gentleman hailing from Karnataka was referred to our endocrine outpatient department for preoperative evaluation of pituitary adenoma. His chief complaints were neck pain since 1.5 years and generalized weakness from 1 year. History of presenting illness. Initial complaints started as neck pain, which was intermittent, strangulating in nature. It was not associated with any radiation, or it's not aggravated with swallowing or any of neck movements, and it used to get relieved with medication. There was no other history of any neurological signs and neurological symptoms like double vision or hearing problems with deviation of angle of mouth. There was no history suggestive of any motor weakness or sensory abnormalities. There was no history suggestive of any meningeal irritation. He was evaluated by a neurologist prior to presenting to us and was given a possible differential diagnosis of glossopharyngeal neuralgia or somatoform disorder. He was also advised to undergo MRI brain screening, which incidentally detected the cellular lesion. The patient had complaint of generalized weakness from 1 year, complaints of easy fatigability from 1 year, and complaints of constipation since 6 months in the form of passage of hard stools once in 2 days. He also had a complaint of dry skin, which was there from 6 months. He doesn't have any history of cold intolerance, weight gain, or pedal edema. No history of swelling in the neck. No history of any headache, nausea, vomiting, or any visual disturbances. There was no other history suggestive of any other anterior pituitary or posterior pituitary hormone deficiency or excess. There was no history suggestive of any hypothalamic dysfunction in the patient. The past history, he had no similar complaints in the past, no history of any trauma or irradiation to the head. There was no history of any past surgeries, and he doesn't have any other associated systemic illness. Personal history, he consumes mixed diet. He does not belong to an iodine deficient region. His appetite is normal and sleep is normal, and he sleeps 8 hours a day and at a normal pattern. He's not a smoker or an alcoholic. Family history, there were no history of similar complaints in the family. There were no history of thyroid or any autoimmune disorders in the family. There is no history of any pituitary tumors or neck tumors in the family. Sir.
So, Dr. Sidhu, I would like to interrupt here. Can you summarize your case before we go to the examination?
Yes, sir. He's a 62-year-old gentleman hailing from Karnataka who had complaints of neck pain since 1.5 years and generalized weakness since 1 year. He was evaluated by a neurologist outside, giving a probable diagnosis of a glossopharyngeal neuralgia or a somatoform disorder. But the patient had history of symptoms suggestive of hypothyroidism since 1 year in terms of cold intolerance, dry skin, and generalized lethargy.
So where was the neck pain exactly? What was the
sir, neck pain used to start on the one side of the neck, sir. It used to is a strangulating in nature. That's what the patient typically describes, sir, with no radiation or anything. It's in the neck, sir. It's not radiating anywhere. It was not aggravating with any movements also, sir.
So since we are discussing an endocrine case and we know it's a thyroid meeting, so do you think it's a thyroid related pain?
No, sir. No, sir. There was no thyroid related pain. So it's not in front of the neck. And the patient did not have any history of any recent viral fever or viral illness, upper respiratory tract infection, also suggestive of any thyroiditis, sir. So it was not from the thyroid region, sir. It was on sides of the neck.
Side of the neck. That's why he went to the neurologist.
Yes, sir.
And so.
And there was a cellular lesion picked in the MRI, which was taken brain screening, sir. It was not a brain screening. And he was referred to an institute nearby, for further management. As a part of routine preoperative evaluation and management, they have referred the case to us, sir.
Okay, so it's an incidental mass lesion which got picked up. It was a neck pain. You were not expecting a cellular mass. It got incidentally picked up, and that's why an endocrine reference was taken. And when you looked at the patient, what was your impression from the history?
Sir, the patient already had a cellular mass and the symptoms were suggestive of hypothyroidism, sir. So there were possible differential diagnosis of a patient with the primary hypothyroidism and a concomitant supracellular mass, or a patient with a primary hypothyroidism with a presenting with a pituitary hyperplasia were thought of based on the history, sir. Patient had hypothyroidism. And one more thing is, like, at this point of time, we can't say whether it is a central hypothyroidism or a primary hypothyroidism at this point, sir. So it's a cellular mass with a central hypothyroidism was also thought of, sir.
We will think of central hypothyroidism first whenever it comes to a cellular mass. In this case,
Okay, sir.
Okay, we can go ahead with the examination. From history, you know he's grossly hypothyroid.
Yes, sir.
Any and no other hormone excess, or you were not, no involvement of diabetes insipidus, no polyuria, no posterior pituitary involvement was seen, correct?
Yes, sir. Yes, sir. Yes, sir. There was no
Sure.
other axis involved, sir.
Sidhu, we can go ahead.
Yes, sir. Sir, examination, sir. The patient is conscious, coherent, and he's oriented to time, place, and person. His pulse rate was 74 per minute regular, and his blood pressure was 120 by 80. Respiratory rate was 16 cycles per minute, and the temperature of 98.6 Fahrenheit degrees Fahrenheit, sir. His weight is 78 kgs, and with a BMI of 28.3 kgs per meter square, sir. There were no signs of there are no signs like pallor, icterus, cyanosis, clubbing, pedal edema, or any significant lymphadenopathy in the patient, sir. Head-to-toe examination revealed dull faces with a dry skin. There was a grade 1 goiter, which was firm in consistency. It's diffusely enlarged, and it's non-tender. And we were able to see the movement of the thyroid with deglutition, and we were able to get below the swelling, and there were no palpable lymph nodes. Hair and nail examination were normal. There were no Cushingoid or acromegaloid features for the patient, sir. SMR was done for the patient. It revealed an SPL of 11 centimeters, A2, P4, and testicular volume is 25 cc bilaterally, sir.
So,
Sir, shall I continue, sir?
okay, just we'll complete the systemic examination and then summarize.
Yes, sir. Systemic examination, sir. Central nervous system, high of mental functions were normal. Cranial nerves were examined, and it revealed no abnormality. There were no ptosis. Pupils were normal. Color vision was normal, and visual acuity was also 6/6 using a Snellen chart, sir, in both eyes. This fundus, bedside fundus examination was normal, and confrontation test is also normal, sir. And gag reflex is normally present for the patient, sir. Motor system, bulk, tone, and power of the muscles were normal. Deep tendinal reflexes were also normal. There was no delayed relaxation of the reflexes. Bilateral plantar, it's a flexor. Sensory system was normal, and there was no signs of any cerebellar dysfunction. His gait was normal, and there was no signs of any meningeal irritation. Other systemic examination were normal, sir. There were no abnormality detected in cardiovascular system, respiratory system, or abdomen, sir.
So how are you wiser after doing the examination?
No, sir. We just confirmed the patient had the head-to-toe examination. Just the hypothyroidism features were confirmed, and patient we couldn't get any pseudohypertrophy of the muscles or any delayed reflexation of the muscles, suggesting the motor system examination, sir. So we couldn't differentiate between a central or a periphery from the motor nervous system examination.
So and the goiter was?
Grade 1 goiter, sir. It was firm in consistency, sir, and it was diffuse and non-tender, sir.
And was there any examination ruled out any other hormone excess like cortisol or a growth hormone excess?
Yes,
or
sir.
A prolactin excess?
Yes, sir. We have looked for any Cushingoid or any acromegaloid features, sir, but we couldn't find any in the patient.
Not mentioned about B1. What was the breast staging?
So there was no gynecomastia for the patient, sir.
Have you looked for the galactorrhea?
Yes, sir. We have looked for the galactorrhea, sir. No galactorrhea for the patient, sir.
Even in hypothyroid patients, if you're looking for primary hypothyroid, prolactin may be higher.
Anurag, like, if you permit, I'll just want to make a point. Sidhu, the very first answer you should have given when you don't have a breast enlargement, there's no need to look for a galactorrhea.
Okay, sir.
Right?
Exactly. Okay, I agree. So, but with the hypothyroid also, we can have a prolactin excess, and those manifestations of gynecomastia and galactorrhea can happen.
Yes. Yes. Shall I proceed, sir?
Yeah, please.
Sidhu, how does the presence of other hormonal deficiencies or excess, or any presence of any visual findings like a papilledema or a visual field defect would have made difference to your understanding?
Sir, if the patient had a gradual progressive loss of peripheral vision, like bitemporal hemianopia progressing, over a longer duration of time, it suggests a cellular pathology which is extending into the supracellular region, sir. Can be a pituitary hyperplasia secondary to primary hypothyroidism, or it can be a cellular supracellular mass also, sir. Generally, if there are other axes involved, like any other hypersecretion of cortisol or growth hormone, we suspect a existing adenoma in the patient, sir. But that doesn't, if there are no other hormone excess or hormone deficiencies noted, but that doesn't rule out pituitary hyperplasia, sir. It can be still pituitary adenoma or a pituitary hyperplasia, sir.
Right. The presence of other hormonal excess or other hormonal deficiencies is more likely to favor the diagnosis of a possible adenoma, whereas even the presence of visual field defects or a papilledema, though it can be seen in primary hypothyroidism with pituitary hyperplasia, but usually goes with a possible pituitary adenoma. Right? Yeah.
Yes.
Please go ahead, please.
Yes, sir. So investigations. The patient was received with referred with the set of the following investigations from Sathya Sai Institute of Higher Medical Sciences. His renal functions and electrolytes were normal, and total T3 is less than 0.26 nanogram per ml, and a total T4 is 0.83 microgram per deciliter. Serum TSH is greater than 100 micro IU per ml. Plasma cortisol was ATM cortisol is 8.39 microgram per deciliter. Serum prolactin is 22.71 nanogram per ml, which is slightly higher considering the male cutoff range of greater than 20 nanogram per ml. A random GH was also done. It was 0.2 nanogram per ml, and total testosterone was 441 nanogram per deciliter. There was a severe T4 deficiency with a markedly elevated serum TSH levels of greater than 100. And there was no other axis deficiency involved here in this present scenario.
So do your diagnosis is confirmed now, or you're still left with the confusion?
Sir, the TSH being greater than 100 micro IU possibly rules out central cause as this thing, sir.
Okay, so there is a primary hypothyroidism for sure.
Yes, sir. Yes, sir. Primary hypothyroidism with very low T3 and T4 levels, sir.
Okay, so it's a primary hypothyroidism with the cellular mass.
Yes, sir.
So now do you think what is the cellular mass then? What is the most probable thing it could be?
Sir, until now, like there is no other hormone axis involved, sir. It could be either a cellular mass or a pituitary hyperplasia even at this point of time also, sir.
So most probably it is a thyrotrope hyperplasia, correct?
Yes, sir. Yes, sir.
Or you're still thinking of a pituitary adenoma or a coexisting craniopharyngioma, or
it's a possibility is there, sir, even at this point of time.
Okay. So you want to keep that possibility open, but if you look at the MRI, we'll come to know the characteristics of the MRI. Can you show us the MRI details?
Yes, sir. Yes, sir. So this is an MRI dynamic contrast MRI with a MRI cellular with a dynamic contrast protocol was done. So these are the images in T1 and T2 coronal. T1 sir images coronal and sagittal. These are the non-contrast images. It revealed a 1.1 into 1.8 into 1.4 centimeter cellular supracellular dome-shaped mass with mild heterogeneous enhancement. And the posterior pituitary bright spot is seen, and there is no evidence of any paracellular invasions are noted, sir.
A small correction. It's not that what's shown on the first picture is not the enhancement pattern. It's a T1 non-contrast, and there is a small area of hyperintensity sitting over there, right?
Yes, sir. Yes, sir.
Okay, go ahead.
So this is a T1 image and a corresponding T2 image showing its hyperintensity in the T2 also, but the hyperintensity is limited only to the upper part, whereas it's in the lower part, it's again becoming heterogeneous in T2, suggesting it's more of an apoplexy, a hemorrhagic material. This is a dynamic contrast imaging. Which is done at 0, 20, 40, 60 seconds, 80 and 100 and 120 seconds. It showed initially the normal pituitary was iso-intense, and progressively it showed an mild heterogeneous enhancement. And this is a contrast sagittal image showing a pseudocapsule. So this is for the MRI, sir. The perimetry also was done, and perimetry revealed no enlarged blind spot or any hemianopias. Sir?
Sidhu, if we go back to the MRI,
Sir.
so this is a hyperplasia-like mass which is enhancing, except for the area which is T1 bright and T2 bright.
Yes, sir.
And which is not enhancing on contrast.
Yes, sir.
Correct?
Yes,
so
sir.
T1 bright and T2 bright would be, the possibility could be
Rathke's.
Okay. And what else?
Recent bleed.
Hemorrhage, Rathke's clefts, or the unfat, sir, or the possibilities which are both, which can be T1 and T2 bright. So in this possibility, considering it can be a hemorrhage or Rathke's clefts, but these 2 points were differentiated based on the differential. So generally, Rathke's clefts is present as a well localized lesion, which is like completely hyperintense, sir. So here the lower part of the lesion is hypointense with an upper hyperintense part. So mostly suggestive of a hemorrhagic component, sir.
I would like to add here, Sidhu. So in fact, Rathke's clefts can have a differential, characters of the contents, right? Okay. There could be some solid content as well as cystic components. They may also behave differently at different levels, right? Okay. Typically, when you're taking an MRI, the solid component may accumulate in the caudal part and may give a different echo texture at the different sequences. Okay. So still that does not rule out the possibility of this being a Rathke's clefts. And in fact, in enlarged pituitary tumors, Rathke's clefts could be compressed, need not have to be kind of rounded mass.
Okay, sir.
Right.
Okay. Do you have a sagittal cut to see whether what is the location of this cystic part?
No, sir. I couldn't get it in this.
And can it still be a necrosis and a proteinaceous material which is behaving like this? Because if we think it is a hyperplasia, why should it bleed?
Yes. Yes, sir.
Vijay, any suggestion or comments?
The cystic component or cystic degeneration is little unlikely, Anurag, because we don't see that to be a T1 bright. So usually that kind of a proteinaceous appearance will typically goes with the Rathke's clefts only, but not with the cystic degeneration.
Okay, so we would never come to know what it is because
yes, we don't know. Probably we won't be help you even at the end of the discussion what it is. But it's all about discussion. Maybe in the next meeting, probably would be able to help you with what is the exact diagnosis, because the D hallmark, whether it's a hypothyroidism or a tumor, is a follow-up which we are yet to have it.
Sure, sure.
Shall I proceed, sir?
Yeah, please.
Perimetry is normal, sir. And ENT examination was also done, which revealed normal oral cavity with a normal throat and ear examination, sir. So the summary is a 62-year-old gentleman who was referred in view of a cellular lesion with symptoms like weakness, lethargy, dry skin, and constipation, with grade 1 goiter and without headache, visual field disturbances or signs of raised ICT, no deficiency or excess of other pituitary hormone axis, and no neurological deficit, sir. So it's a case of pituitary mass with a markedly elevated TSH and low T3 and T4. So the differential diagnosis in this condition would probably be a non-functioning pituitary adenoma with a coexisting primary hypothyroidism based on the MRI features, and pituitary hyperplasia secondary to primary hypothyroidism would come next in the list, sir.
Sidhu, which will you keep first? The first one first or the second one first?
Sir, in this scenario, I would like to keep at this point of time like the non-functioning pituitary adenoma with a coexisting primary hypothyroidism based on the MRI appearance of having an apoplexy or a lesion, sir. Not clearly would be able to differentiate these, sir. So these are the points which are favoring a hyperplasia.
Sidhu, you don't want to disappoint the surgeon, correct? That's why you're keeping that as a first diagnosis still?
No, sir. Based on MRI features, sir, we tabulated as this thing, and there were a few points which were favoring an adenoma also, sir, like presence of a pseudocapsule, an apoplexy in that, and a mild heterogeneous enhancement of the lesion. I'd still suggest adenoma as a probable differential diagnosis at this point of time, sir.
But you have how many ticks towards hyperplasia?
Very high TSS levels favors hyperplasia, sir, but it can be seen in a primary hypothyroidism with adenoma also. Whereas a patient had dome-shaped, smooth border, it's more in favor of hyperplasia, and no invasion. It's favoring hyperplasia, but it can be there in adenoma also, sir. And there was no other axis involved, so like deficiency or hypersecretion. It could still be both hyperplasia or adenoma, sir.
Okay, sure.
So the management plan for the patient was, since there was no significant optic chiasm compression or any other mass effects, repeating MRI after fully replacing levothyroxine for 3 months was suggested. Thyroxine sodium was started at the dose of 50 micrograms once a day in empty stomach, 1 hour before food for 2 weeks, then escalated to 100 micrograms once a day, sir, to continue, and to review after 3 months with thyroid profile and an MRI cella, sir.
Sure.
Sir. Discussion, sir. So pituitary hyperplasia is an under-recognized manifestation that can commonly occur in primary hypothyroidism. This is a proposed mechanism for thyroid enlargement or pituitary hyperplasia in case of a primary hypothyroidism. Very low T3 and T4 levels will cause loss of negative feedback inhibition on TRH release, and which in turn, the TRH will in turn act on thyrotropes and lactotropes, causes hyperplasia. So causes thyrotrope hyperplasia as well as lactotrope hyperplasia. So. And lactotrope hyperplasia commonly associated with the hyperprolactinemia, and these patients can present with symptoms like galactorrhea. Hence, the presentation and imaging can mimic a pituitary mass, most commonly a prolactinoma, sir. So even though the thyrotropes can compress about 5 to 10% of total cell types, but they can release in significant enlargement of the gland, sir. So lactotrope hyperplasia also contributes to some extent, sir. So these are the images taken from an electron microscope view. This is a image of a enlarged thyrotrope cell, sir. This is an image of an enlarged lactotrope cell, sir. So in both of the pictures, we can see multiple Golgi complexes with the multiple lysosomes and secretory granules and a prominent nucleolus, sir. Even here also there are multiple lysosomes with multiple secretory granules, which are also in secreting phase, sir. And in a study including 53 patients with TSH, in a study, sir, we have reviewed a study which was done in a 53 patients with a TSH of more than 50 micro IU per ml, sir. Out of them, 70% had a pituitary enlargement, sir. Out of the total 53 patients, and 84% of the patients had pituitary enlargement who were having TSH levels of greater than 100, sir. And 85% of the patients showed significant reduction in pituitary size following thyroxine replacement, sir. Only 2 of them had a slight enlargement in the follow-up, sir, the pituitary size. And 2-3 patients were remained stable, sir, But most of them responded to levothyroxine therapy, sir. So our previous experience with coexisting pituitary adenoma and primary hypothyroidism. So these are the other 2. We had another 2 patients who presented like this. So this is a case of a pituitary macroadenoma and with a slightly raised prolactin levels of 240, sir. So macroprolactinomia also, macroprolactinoma was also considered as a differential diagnosis. In this case, the patient had a NOST4 lesion which is extending into the base of the third ventricle. So in this, like, it's a clear-cut case of an adenoma was made, and this cannot be a hyperplasia. And this is also a significant macroadenoma which is compressing to the third of the base of the ventricle. And this was also associated with other hormone axis involvement like hypogonadism and hypocortisolism. Even the patient had other axis deficiencies, even still thyrotropes were able to manage to put up a level of more than 100 micro IU per ml, sir, with a macroadenoma. So this led us to think to the point that the ability of thyrotropes to maintain high levels of TSH in patients with primary hypothyroidism and coexisting macroadenoma, sir, even while the other pituitary tissue is under compression, reflects the potential of thyrotropes to increase the functional capacity by several folds and to and achieve a greater compensation than other axes. Similar phenomena is also observed in some patients with primary hypothyroidism and with coexisting empty cella supporting our observation, sir. Levels as high as 50 micro IU per ml have been documented in empty cella patients with primary hypothyroidism. So in situations like this, the point we thought of few points which could differentiate between adenoma and hyperplasia. So based on the clinical history, serum TSH levels favoring in an adenoma or normal, low, or slightly high. Generally, if the levels are very high, we think it favors more of a thyroid of hyperplasia without the set of investigations or MRI. Presence of any other axis deficiency can be seen in both in an adenoma, whereas it's generally absent in hyperplasia. And other axis hypersecretion can be seen in adenoma only, but it is not seen with hyperplasia. So, and when it comes to an MRI imaging point of view, the points which favor adenoma and which favor hyperplasia are the presence of paracellular invasion definitely points towards an adenoma, and a supracellular bulge shape, which is termed nipple sign in many journals, can be seen in hyperplasia, sir. Apoplexia cystic degeneration can be seen in adenoma, whereas generally it is not seen in hyperplasia. Enhancement is generally can be heterogeneous in adenoma, whereas generally it is homogeneous in hyperplasia. The presence of pseudocapsule favors an adenoma, whereas a response to levothyroxine after correction of these thyroid hormones will regression will definitely point out towards the hyperplasia rather than an adenoma. So these are the images of pituitary hyperplasia. These are the which we can see the typical nipple shaped over here, like being that is why it's being coined as a nipple sign. And pituitary hyperplasia can present in many of the heights. So this is starting from very mild convexity to the frank globular supracellular lesion. The follow-up, sir, to confirm the diagnosis of pituitary hyperplasia as a result of primary hypothyroidism, there should be a definite reduction in the pituitary size with thyroxine replacement, sir. Even though the timing is variable, many studies have noted the regression of hyperplasia within 1 week, but the usual duration which takes is about 2 to 4 months, sir. Hence, usually imaging is recommended 3 months after the initiation of levothyroxine therapy. If there is no noted progression in the size of the pituitary despite initiation of treatment, surgery may be required to establish a diagnosis of the pathology, sir. So our patient is due for follow-up MRI and thyroid function test. He'll be back in 30 days, sir. So we are yet to know what is the pathology behind it, sir. Thank you, sir.
Thank you, Sidhu, for the detailed discussion. I think it's most likely to be hyperplasia. We wish for the same, and patient may not require any surgery. But if we get surprises, please let us know.
Okay, sir. Sure, sir.
Anurag, there are also a few questions, so probably we need to address them. Dr. Syed has asked whether Rathke's clefts are usually located in the midline, but in this case, it's located laterally.
Exactly. The sagittal cut, if we look at, we will get a better idea.
In the coronal, it was definitely lateral.
Yeah. But sometimes maybe near the stalk, we can get, but the sagittal cut gives a clear idea. And with the presence of this hyperplasia, how would a Rathke cyst be displaced or not is very difficult to answer.
Yes, especially in an adenoma, it definitely can be displaced depending on the growth phase of the tumor, right? So Dr. Pankaj is asking what are the cortisol and prolactin levels in NFPA. I think Sidhu mentioned it was an hypocortisolemic patient. And prolactin levels, do you remember, Sidhu? What was the prolactin level?
243 nanogram per ml.
No, not the prolactinoma patient, the other NFPA patient who underwent surgery.
Sir, 53, sir.
53.
I have the slide, sir. Should I?
That's okay. So, in fact, the patient also underwent surgery and IHC has been done. It's prolactin negative. So, it's not a prolactinoma and it's a clear diagnosis of NFPA has been made for that patient. Dr. Rana is asking, like, his comment is sphenoid sinus mucosal hypertrophy would favor adenoma plus minus apoplexy. Definitely, the sphenoid sinus mucosal hypertrophy is a very good sign of apoplexy, though less likely of an adenoma without apoplexy. But if that would have been there, definitely that favors an apoplexy. I would agree with that.
But Vijay, we are talking not about an acute apoplectic event which have a sphenoid sinus mucosal thickness. We're looking about a chronic hemorrhagic.
Yeah, it's more of an intratumoral bleed. Yes. Probably we won't be able to label it as an apoplexy.
Correct.
But like I think, but I would accept Rana's point, because if at all, if it would have been present, then probably definitely it favors an adenoma over hyperplasia.
Sure.
And again, very tricky question from Dr. Pankaj. Why homogeneous enhancement in hyperplasia? So probably it's just, you want to answer this, Sidhu?
Sir, yes, sir. In hyperplasia, generally it is a uniform thyrotrope hyperplasia. So it's a normal structure, sir. So we won't expect any changes in enhancement. It will be iso-intense with the other rest of the pituitary, sir.
Right. So it's also a slow enlargement with a concomitant or a concurrent increase in the vascularity. So unlike in adenoma, where the vascularity often gets interrupted in places and vascularity may not be sufficient to support a particular area of the adenoma, in hyperplasia, it is usually gradually increasing mass with a concurrently concurring vascularity. So that's the reason why there will be a homogeneous enhancement in hyperplasia. I think we have addressed all the questions. Anurag, any more comments you would like to?
Vijay, I think we have extensively covered this case. Congratulations, Sidhu, for the presentation.
Thank you.
And thank you, Vijay, for coordinating it so nicely.
Very sincere thanks, Anurag, for taking out this session. And you are, in fact, one of the best person to handle something related to pituitary. We are really glad to have you here. So with this comments, I would like to hand over to Ganani. Ma'am, Sarita ma'am, any comments from your end?
Yeah, I think the jury is yet to be out because we have to wait. And I think either Vijay or Sidhu have to get back 2 weeks from, no, you said how many days left for the patient to come back from now?
Maybe September 1st week he will be undergoing, ma'am. So probably maybe 2 sessions down the line, we should be able to give the answer.
Okay, so we'll keep, not 7 September is our next session. So maybe you will not be there for the 7th. I mean, we're not sure. So we'll confirm with you. Definitely. So Gandhi, just keep a note of that.
Yes, ma'am.
In case the jury is out on the 7th or the next, so that we must have them back. Yes. Because that is usually what we do for case presentations anyway. I know we have a follow-up of what was presented the week before or the fortnight before, to make. So I think let's wait. It's fascinating.
So we'll update you with the
fascinating. And thank you, Vijay, for those cases, Sidhu, for the presentation, and Anurag for the wonderful moderation. Thank you. Thank you. Over to you, Ganvi now.
Yes. Thank you, Dr. Anurag, sir, and Dr. Sidhu for a very gripping discussion. I now request Dr. Nalini Madam to share the answers for the quiz questions and then to announce the quiz winners.
Let me share my screen.
Yes, please.
Right. Is my screen visible?
Not yet, ma'am. Yes, ma'am. It's visible.
Yes. Right. So those were the few questions. I hope they made you think a lot, and I hope they confused you a little too. Moving on to the answers, the first question was that of a 26-year-old man who presented with a mobile neck mass. Clinically, when you look at it, it more or less looks like a thyroglossal duct cyst. It's very mobile and anterior neck mass. But FNAC clinches a diagnosis. It says, you can clearly see here the papillary carcinoma picture, the orphan anide nucleus. Can you see my pointer?
No, now you're
right. Can you see this here?
Yeah. You
can very clearly see the orphan anide nuclei out there. So orphan anide nuclei are pathognomonic for papillary carcinoma. Although it's clinically, as I said, it clinically resembles thyroglossal cyst. Histology confirms the diagnosis. So never take it easy whenever a person comes. That's the take-home message here. 26-year-old man, you wouldn't be expecting to see something very mobile neck mass. Don't reassure and send. Do the FNAC, and then that can change your diagnosis. So the second question was, which of the following is not a feature typical for Graves' disease? So the answer for this is B, extensive infiltration of mononuclear cells into thyroid parenchyma is a feature of thyroiditis. It's not seen in Graves. All the other features like the hypoplasia, irregular follicles, and scalloping of colloid, all of them we see in Graves, but we don't see the infiltration. Extensive infiltration is seen in Hashimoto's. And in Graves' disease, IgG, TSH like autoantibodies, they cause the stimulation of TSH receptor, causing hyperplasia of the follicles. These follicles are irregular in shape. It's not a controlled growth. So they are irregular in shape and they display the scalloping of the colloid. So the third question, how many isotopes of radioactive iodine exist? The answer is, the question is actually seems a direct question, but is a little confusing. The total radioactive isotopes of iodine are 37. The total isotopes of iodine are 37. Of them, 36 are radioactive and only 1 is non-radioactive. So isotopes of radioactive iodine are 36. Iodine are 37. This is taken from the United States Environmental Protection Agency document, that there are 37 known isotopes of iodine and only 1 of them is not radioactive, which is iodine, the native iodine, iodine 127. Fourth question, the probable mechanism by which metformin reduces TSH levels are all except metformin increases the central dopaminergic tone. It doesn't decrease the tone. So rest of them are correct. It increases the central dopaminergic tone. That is the answer here. So fifth one, what is the usual peak? This is a direct question. 4th and 5th decade. It's even given in the textbooks. Usual peak incidence of thyroiditis is in 4th and 5th decade. Sixth question. In 2013, Ministry of Health and Family Welfare launched a child health screening and early intervention service, which included thyroid screening as well. The program's name is RBSK program. And this is the document, the job aid document that you see here in the slide. It's called RBSK. We need to know our programs. We need to know what government is doing for us and what is lacking and what we need to push for. So the knowledge of these programs is very essential if we are trying to change a lot of things which are going on in the society. Seventh question, during the revision surgery of thyroid gland, the risk of parathyroid injury is estimated to be about 10 times. So revision surgery should always be avoided. And this is one of the major reasons why it is. And those are your references out there. You can refer to. So the general estimate is about 10 times. Eighth one, this is an easy answer. So the descending order is placement of the order, especially when the question comes in the last, puts you a lot of pressure on. So this is what is needed for this question. You all know that anaplastic carcinoma, the survival rate is 20 to 35%, followed by medullary. 10-year survival is 50%, and then follicular 92%, and papillary has the best prognosis of all. 98% survival is seen at 10 years. So the answer is A, anaplastic is greater than medullary, is greater than follicular, is greater than papillary. So the ninth question, this is a little bigger explanation is there. The treatment options for methimazole-induced hepatotoxicity is intravascular glutathione. And why? You need to understand a little of the mechanism, which is very important here. Methimazole-induced hepatotoxicity is typically a cholestatic process. Why? What contributes to this? There's a lot of factors which contribute to it. With regards specifically to methimazole, what is happening? It is metabolized through CYP450 pathway. And it gives rise to two major metabolites, N-methylthiourea and glyoxal. N-methylthiourea is further, it goes into monoxidase pathway through FMO and gives rise to a lot of sulfur compounds. Thiourea, right? It's a sulfur compound. Gives rise to a lot of sulfur compounds. This compound is proposed to be the main active substance which is considered to cause the hepatotoxicity. That and its metabolite, the sulfonic acids, they cause a lot of changes and mayhem in the intracellular environment, and that leads to hepatotoxicity. And not just that, the glyoxal which comes out, the glyoxal pathway gets saturated very easily in the body. So this glyoxal pathway is a very reactive compound and it damages a lot of proteins. So what is the role of glutathione? Glutathione, as you know, it prevents this kind of a cytochrome oxidation and FMO related degradation, which can put the person at a risk of methimazole-induced hepatotoxicity. So it prevents that. But this glutathione content, the reduced glutathione content, is very much variable in the tissues, and especially the liver tissue. And it's prone to many changes. Like if a person is alcoholic, the pathway is totally saturated. There is no reduced glutathione to protect your liver. So the person is prone to hepatotoxicity with methimazole. So we should avoid alcoholism while a person is on alcohol intake, while the person is on methimazole. That's the important point here that one needs to remember. And then there's another proposed mechanism This is all a lot of cellular chemistry that goes on here. Glutathione reductase activity, it's considered low to have be lower. So when glutathione reductase is lower, the regeneration of reduced glutathione is not there. Oxidative mayhem happens out there and damage, and then hepatotoxicity. So these are the important points that we need to learn from this question. And the last question is a simple one. An 18-year-old female presents with a painless 1 centimeter anterior neck mass. Biopsy was taken. See, again, we did not leave the patient aside. An FNAC biopsy was done, and the fluid revealed contained pseudo-stratified columnar epithelium. That clinches your diagnosis that pseudo-stratified columnar epithelium is present in the thyroglossus cyst. So B is your answer. Thank you so much. Let me thank Sarita ma'am and the organizers for giving me this opportunity.
Thank you, Nalini. I'm sure everybody enjoyed participating, and that was an excellent quiz with wonderful explanation as well. So over to you, Gandhi. And just Nalini has to be around to announce the winners.
Yes, ma'am.
Asmita, can we have the slide, the winner slide? Yeah.
We have 3 winners here.
Yeah.
Dr. Parag Agrawal, Dr. LKS, it would be good if we had known the full name, and then Dr. Shruti Ravindra. Congratulations.
Thank you, ma'am.
Thank you. If you can vocalize for Parag, so he's waiting for the certificates of the previous winning thing.
Yeah, that I've made sure that he'll get it. Pakka last time, Bala, and this time also, don't worry.
Thank you, ma'am.
I'm sorry for the mess up, because the IT team has specific instructions. As soon as the meeting is over, they're supposed to some glitch somewhere. We'll have it sorted out.
No worries, ma'am. Thank you.
Please do log in for the next thyroid clinics, which will be conducted on 7th of September. The program will be chaired by Dr. Naresh Bansal, sir. We have a dialogue next time on thyroid disorders in pregnancy by Dr. Vikram Shekhawat, sir, and Dr. Amit Nachankar, followed by quiz by Dr. Shaila Sheikh, ma'am. Following the quiz, we have a monologue on thyroid and bone by Dr. Amrish Mittal, sir. So with Dr. Sarita madam's permission, we shall be concluding today's program. Ma'am, I would like to ask you to deliver a few words.
Pramila hasn't spoken today. Is she around? We just have Pramila. Unmute.
Yeah. Ma'am, I'm around, ma'am.
Missing your lovely voice.
No, ma'am, I'm around only. I'm there only.
Yeah, I know you are there, but...
Yeah, this discussion was so good today. So we all learned also a lot of things. So it was a very good discussion. The quiz was fantastic, I think. Dr. Lakshmi Nalini had brought a lot of good questions and difficult and tough questions.
70% are from our thyroid journal, ma'am.
Yes. That's a good.
Couple of them are from your own work.
Yeah.
And
I appreciate that because we are trying to promote our journal. So that's a good thing. Dr. Nalini has done a very nice thing today because I appreciate that, because that's what we are trying to tell, that we have our own Thyroid Society journal, which we should send our articles to, because that belongs to our society. So we should all publish in that.
So I think the previous quiz master, Autindra Maisnam, has requested that we have a specific topic for the quiz.
Right, ma'am.
So I think, why don't we have all the questions from our journal?
Right, ma'am.
10 questions, and there must be a lot of articles which are being published or have been published. So from thyroid research and practice. Anyway, this is just a passing thought. Right. But I think we have to let the quiz master at their discretion about what questions they choose. I think that's only fair. So I think we can close now. And very, very special thanks to Vijay for chairing so nicely, and Dr. Maithili and Anurag for conducting or moderating the case discussion, just exactly the way it should be done. And both the cases, extremely interesting. On the first one with the hypothyroidism, and idiopathic intracranial hypertension. And the second one, it's incidentaloma with primary hypothyroidism and non-functioning pituitary adenoma with coexisting primary hypothyroidism. We still have to wait for the answer to that one. So thank you very much. And of course, the quiz by Nalini with the explanation. Thank you. Thank you so much. And of course, Pramila, Minnie, Arun, who are with us for every meeting. Thank you so much. And our rapporteur, a dynamic rapporteur who's busy throughout preparing for the next meeting and making sure that things are in order. Thank you, Gandhi. Thank you so much. Congratulations to Parag Agarwal and LKS. Please let us know what your details are. Otherwise, we'll not be able to send you the certificate. And Shruti, what was the last? The last winner, Shrika, I'm sorry. I'm not sure about the name there.
Shruti
So,
Ravinder, ma'am.
Yeah, Ravinder. Okay, so congratulations to the winners for the quiz. And thank you to our digital team being represented by Ashmita and Priyanka from Metasage. Thank you. Thank you so much. Very, very good night to everyone.
Thank you, ma'am. Good night.
Good
Good
night,
night, everyone.
Good night.
Thank you, ma'am.
Good night.
Good night.
Thank you all. Good night.